The pre-hospital component. We touched briefly on the pre-hospital component in the last module. Let's take a deeper dive. For the best possible outcomes of trauma patients, good care must start from the beginning, making pre-hospital care an important part of the team concept. Knowing and understanding your EMS system is imperative for a good continuum of care. The Montana Board of Medical Examiners establishes the requirements and issues a professional license for all levels of emergency care providers. The EMS and Trauma Systems section is responsible for the licensing and regulation of pre-hospital emergency medical services, including ground ambulance services, air ambulance services, and non-transporting medical units. Now let's get to know each type of emergency care provider in Montana. Feel free to pause the video at any point to read more detailed information. Emergency medical responders, EMRs, typically render on-scene emergency care while awaiting EMS response. They may serve as part of the transporting crew, but not as the primary caregiver. Here you see the psychomotor skills that they need to be proficient at. Here we continue with the psychomotor skills of EMRs, including an optional endorsement. Now we go to emergency medical technicians. The major difference between the EMR and the EMT is the knowledge and skills necessary to provide medical transport of emergency patients. See here the psychomotor skills required in addition to those of an EMR. Here we continue with the psychomotor skills of EMTs, including optional endorsements. Here are some more potential endorsements for an EMT. Advanced EMTs, or AEMTs, are next. The major difference between an AEMT and an EMT is the ability to perform limited advanced skills and provide pharmacological interventions to emergency patients. The list of psychomotor skills are listed over the next few slides. AEMTs can also pursue endorsements. The highest level of care comes from paramedics. Paramedics can perform a broader range of advanced skills than AEMTs. See the next few slides for required psychomotor skills and potential endorsements. An ECP's practice is, by statute, limited to the out-of-hospital scene. Some Montana hospitals, however, recognizing the skills and training of the certified ECP, have begun to employ ECPs in the hospital emergency room and other in-hospital settings. Typically, the facility lists ECP licensure as a criterion for employment and then trains the person in such additional skills and techniques as may be necessary to perform the in-hospital job. For example, phlebotomy. The facility may call the employee an emergency department technician or emergency room assistant. Such employment practices are cost-effective for the facilities because they can send the employees out to the scene of an accident on an emergency call as a fully certified ECP, and when the run is completed, can use the same employee for routine in-hospital tasks instead of having to employ an additional unlicensed person for those tasks. It is the position of the Montana Board of Medical Examiners that emergency care providers who begin initial patient care as part of their normal out-of-hospital response may continue the patient's care in the medical facility under the following provisions. 1. The care rendered in the facility is at the request of the medical provider, and 2. The emergency medical provider operates within their individual scope of practice at all times. EMS and Trauma Systems often offers courses in emergency pediatric care and pre-hospital trauma life support for EMS communities. Contact them for more information on what is currently available. There are a variety of training opportunities available to supplement an ECP's knowledge and skill base, including community education programs. Medical directors are authorized to use board-approved protocols in their entirety or may determine to limit the service or individual EMT provider's function and practice where appropriate and in accordance with the provider's abilities or needs of the community they serve. However, the local medical director may not significantly alter or expand approved board protocols without first seeking Board of Medical Examiners approval. The protocols are written more with a what to do versus how to do it, so there may be some difference from system to system on how care is provided for specific issues depending on the specific medical director. Local medical direction establishes the utilization of any and all psychomotor skills allowed within the Montana state protocols. With an understanding of who the pre-hospital caregivers are, what their skills are, and which protocols they must follow, what should happen at the scene. On scene, responders are limited to what is necessary. Primary includes the ABCs with a find it and fix it approach. If you cannot fix it, you must transport immediately. If you can fix, then expose and conduct a very quick, appropriate secondary, and then package the patient for transport. En route care requires the following: reassessment of the ABCs and any treatments performed to ensure that they're still working. Early notification to hospital for trauma team activation if they meet criteria. Vital signs including pulse oximetry. If able and time allows, establish IVs appropriate for the patient. If time allows, a more thorough head-to-toe evaluation of patient with time to completely expose if you were not able to on the scene. Notify the hospital with an update and more thorough report. And remember that trauma patients change quickly, so continual reassessment of the ABCs may be the only thing you can do en route. Possible pre-hospital treatments are listed here for both BLS and ALS responders. The incident has occurred, EMS is responding, so we now ask, what situations warrant the activation of the whole trauma team? Let's discuss the trauma team activation criteria. EMS and facilities should utilize these criteria to identify patients needing trauma team activation. Goals for all phases of care include early identification, communications with EMS and medical control in facilities, and notification to enhance effectiveness. While these criteria are presented in sequential fashion, using all applicable criteria to identify significantly injured patients is advised. Trauma patients with severe injuries should be transported preferentially to the highest level of care within the trauma system geographically available. Steps 1 and 2 attempt to identify these patients. Remember, when in doubt, activate or contact medical control. The following slides can be found in the resources module for future reference. Please pause at any point to read more information. Step 1 is physiologic criteria. If none of these are present, proceed to step 2. Step 2, anatomic criteria. If your patient does not present with any of these, go to step 3. Step 3, mechanism of injury criteria. MOIs do not always produce severe injury, but they can, so you should consider activation based on this information. If you still say no to all of these, go to step 4. Step 4 are special considerations or comorbidities. Underlying issues can create a higher risk for severe injury and may lead to activating the trauma team response. Air medical transport typically is a consideration for scene evacuation of critically injured trauma victims or for the interfacility transfer of high acuity patients to tertiary hospitals. The appropriate activation and effective utilization of air medical transport services is an important consideration for emergency care systems. The purpose of the Montana Air Medical Activation Guidelines is to provide guidance for development of standardized approaches for ground emergency medical service providers to decide whether or not to request a scene response by an air medical transport provider. As there cannot be a single document developed to meet the needs for every situation, the Montana Air Activation Guidance is provided as the foundation for local decisions about implementation of air activation criteria. In certain scenarios, the patient cannot be fully stabilized at a local facility, or there are no local facilities in close proximity to the scene. Such patients should be considered a candidate for air medical transport to an appropriate facility. The specific criteria listed in the guidelines are not intended to be a comprehensive listing, but rather an indication of the decisions for whether or not air medical response may be appropriate. Click the link in the resources to access the guidelines. EMS communication is key to making sure trauma patients are well taken care of. Communication avenues to consider are when communicating to other responding agencies, when requesting additional resources, when seeking higher level care or flight services, or early notification to the receiving facility. Early notification to the hospital is important, especially if their resources must be called in, a trauma activation is occurring, or if a flight team needs to be mobilized. EMS reports should be simple, pertinent, and concise. Reasons for this are emergency department staff receiving calls are often busy with multiple priorities, radio communications are often spotty and break up easily, and emergency department staff need to know enough to make triage decisions, like do we activate the trauma team, do we free up or call in staff, resources, and diagnostics, which ED space can we use, and do we need to move current patients. The MIVT or MIVT report is a good template to use. It relays the mechanism of injury, the injuries suspected, the vital signs collected and Glasgow Coma Scale, and any treatment started. Once at the emergency department, quick communication should include the MIVT report, any changes after treatment, past medical history, allergies, and medications. EMS may provide assistance at the direction of the hospital personnel. An EMS patient care drop sheet should be completed and left with the ED before leaving. Per Montana EMS service licensing statutes and rules, each emergency medical service must maintain a patient care record for every EMS incident. In incidents where more than one patient is encountered, one patient care record shall be completed for each patient. Electronic data submitted to the department must be in the format prescribed by the National Emergency Medical Services Information System. Immediately or as soon as possible upon arrival at a receiving facility, but no later than 24 hours after the end of the patient transport, an ambulance service must provide a copy of the patient care report to the hospital that receives the patient. Not only is it a rule to provide documentation, always remember, it provides an important continuum of care. Although we give face-to-face reports to the hospital on arrival, much of the information we have is not always heard correctly or written down. We see things such as mechanism of injury and how the patient was before any treatment was rendered. This information is very valuable to those that will be continuing to care for the patient. It is protection for you. You are a healthcare provider and unfortunately may someday be questioned about your care or what happened with the patient. If you didn't document it, you didn't do it. EMS has always been interested in improving the care that they provide, but haven't necessarily had a method to document the improvements they have been made. Pre-hospital performance improvement is best done as a collaborative between pre-hospital and hospital personnel. Is anyone in your service monitoring quality? Don't only evaluate big cases for which you know there are problems. Evaluate the entire categories of calls. Look for problems you don't already know about with the goal of finding system issues before a patient suffers. It's not about assigning blame, it's about making it better for the next patient.